We've done 56 lectures this year around the country, and we have 3.5 employees. So if you can kind of imagine how much energy and time to get the educational materials together for the patients, and it takes, we're stretched really thin, but we're really grateful because we have such stellar lecturers coming around. And the other thing I want to tell you that we've worked on and accomplished is that the common data elements, common data instruments, and clinical research forms that we were working on for the National Institute of Health and the National Institute of Rare Disorders, they tasked us with creating a dictionary for Chiari and Syringomyelia so that when researchers go to do their research, they can find standard terms. So when you look at a paper that's published by somebody, it'll have the same terms and same way to measure things, so you can compare apples to apples, which really hasn't been done up to this point, and you find a lot of discrepancy between how someone measures things, or what terms they're using to define a procedure or piece of the anatomy. So it really is a huge accomplishment, and now with this in place, we're actually at a point where we can use those elements to work on the international registry. So we're going to start really small. We've been given a $25,000 grant by Robert Wood Johnson. And with that money, we're teaming up with the Genetic Alliance, which has a few different groups in it. And we're working on basic questions to a registry. So you're going to be seeing things in an email that asks you to register. It's really the first step. So it'll be selecting your privacy and your basic demographics and what you've been diagnosed with, how you were diagnosed, and also quality of life. Really a very, very simple survey. From there, when we go forward with research, there'll be another set of questions that come in. But when a doctor wants to do that or a scientist wants to do that, they have to do an IRB to make sure that the questions are being asked in the right way. And that will then come to the scientific board, and assuming everything is great, you'll get this set of questions, and you can opt to answer and participate in that program or not. So I encourage you all, when you get this, if you really want to change research going forward for these populations, if you participate, it would be really, really helpful. So keep a lookout for those. Does anyone have any questions on that? Okay. So now it's really my pleasure tonight to introduce our treasure for the evening. Dr. Souweidane currently serves as the Vice Chairman and the Department of Neurological Surgery and the Director of Pediatric Neurological Surgery at Weill Cornell and Sloan Kettering. He's Associate Professor in the Neurological Surgery and Pediatrics, and he's also a member of the CSF Medical Board. He's dedicated his career to children for brain and spinal disorders. And I think the thing that makes him stand out is truly his bedside manner. Like, he's such a caring, warm individual, and I know that that is a comfort to families who come in with a child. So we're very appreciative of that quality that he has. He is a tumor specialist, and he's pioneered ways to operate on specific tumors, but he's also an expert in Chiari and Syringomyelia. So tonight, it really is my pleasure to introduce Dr. Souweidane to lecture on Chiari Malformation and Syrinx. Please give him a warm welcome.
It's always odd having a friend introduce you. I've been called a lot of things today, and treasure is certainly at the top of that list. Yeah. So Dorothy, Caitlin, many, many thanks for organizing It's always, I think, and listening to you talk about the common data elements, I just want to annotate something, and that is, for individuals who don't believe that patient advocacy groups can change the playing field of medical therapeutics and diagnostics, nothing is farther from the truth. As mentioned, I live in a world of not just Chiari and Syrinx, but also brain tumors in children. And you watch the evolution of kind of the agenda set forth, and so much of that today is being driven by foundations, philanthropic funding, patient advocacy groups, and it's something that I could never, 20 years into this, have ever envisioned that has the power and the wherewithal. This is not a scientific body, it's not the peer-reviewed journal, it's not the federal government funding a source, but these are individuals who have their heart and soul and blood into a certain sentiment and a feeling. And there's no question in my mind that something like the common data elements and the unification of investigators using the same language will remarkably change what we know about Chiari and the optimal forms of therapeutics and diagnostics. And anybody sitting in this room knows that the nebulous aspect of Chiari and some of the mystique is built around individual anecdotal experience. And experience plays a large part, I don't want to discount it, but the fact that we don't always speak the same language when we're talking about diagnostic or response issues is a big, big problem. And I applaud CSF for really pushing that agenda forward. And they will have the power, and they will have the value and the reward of changing the way we practice that research, that clinical research. So I'm looking forward to that, and I look forward to playing a part in the registry and international information that's going to come from that. I'm going to indulge us, hopefully in a very informal way, on the element of Syringomyelia, most of it relating to Chiari, and that will be the emphasis. But I'm really going to give you my insight, kind of what's published with regard to our understanding of the presence of that entity, the optimal forms of treatment, diagnosing, and really the way about treating this disease when primary forms of therapy don't always work. Before I get into the substance of Syringomyelia, Jordan was kind enough to, I think, or maybe through the CSF, aggregate some of the questions that came in, I think, after our last lecture series on, some of you maybe sitting in this room who have posed some of these questions. I'm going to throw these up there. I'm not going to answer these, at least not now, and hopefully I'll answer them in an indirect way. And at the end of the talk, we'll go over these again. If they haven't been answered in the content of this talk, we can certainly revisit some of those. But take a good look at those. And again, as we go through the talk, I think at least 2/3 of these should be fairly obvious as far as the answer. And if not, as I mentioned, I promise we will talk about those. And some of these are a real interest of mine, such as Chiari 0 and the natural evolution of Syrinx and Chiari, which are very, very important clinical questions. Excuse me. And as Jordan, and I think with Roseanne's help, have been able to initiate, some of the feedback from our last talk was they love the interaction, they love the questionnaires, they love the videos, and they love Dr. Greenfield's humor. Some of that I can't supply tonight, but some of the other elements we can. But some of the questions that we asked the audience to participate in are some of the basic demographics of what we're looking at today. So, and I think most everybody has already logged in and answered these questions. So in a moment when I go through the first couple, we'll go back and look at those responses, I think in the same order, right? So question 1, how far have you traveled to today's lecture? Do you have a diagnosis of Chiari? And do you have a diagnosis of Syringomyelia? And do you have a diagnosis of both? And that should, I'm going to guess, accommodate most of the positive responses as we look at that. And I'm told, if I can see. So how far have you traveled for today's lecture series? Let's look at some of the results. 1 vote. Is that right? 1 respondent, no. Is that right? No?
Refresh.
Refresh. Tell me how to refresh.
F5.
F5? Oh, I love that. It did it on its own. 11, thank you. So the overwhelming majority, obviously, in New York. Really, I don't see New Jersey as any separation from New York other than maybe a body of water, but geographically. So all within the area is what we would expect, especially when you're giving, how many lectures did you say in how many days? Yeah, the penetrance is amazing. So you shouldn't have to travel very far to hear educational lectures on the topics. And going to the next question, Roseanne.
Scroll down a little bit.
Just scroll down. You're making this easy.
Go to question number 2.
Wow. Do you have a diagnosis of Chiari? I would hope most of these are going to be positive. So of 11, no, interesting. So less than half, which I'm interested to know why the other half are here, but maybe we'll get to it with Syrinx. Time will tell. And you'll hear that, by the way, the two, although we think of them hand in hand, they're not requisites of either diagnoses. Question number 4, do you have a diagnosis of Syrinx? So interesting, I would have expected kind of the reciprocal, but we're not seeing that. So the overwhelming majority don't. And we're going to go over this a little bit more, but of those individuals with surgically treated Chiari in most large series, up about 80% of patients will have Syrinx in that population. Depends again on who the consumer is or who the driver is, but so this is a bit unusual, and not what I would have predicted. And then both. So out of 11, it looks like only one patient or one person has both the diagnosis of Syrinx and Chiari, which is not unusual in a surgical series, not unusual, and actually probably the norm if you look at just a clinical series. If I look at all patients that come into the office, excluding those that end up getting surgery, it's probably closer to that 10% range that have a Syrinx at the time of my evaluation. Right? And that's all comers with a radiographic diagnosis of Chiari, which in of itself is a challenge sometime as well. So thank you for participating. We're going to come back to those in a moment. And let's go right back into the gist of today's lecture, and that is Syrinx. So I'm going to give you some very brief anatomical lessons, and then go over some of the terminology, which I think is extremely important. In a cross section of the spinal cord, which is this here through essentially the thoracic spinal cord, this would be in front, in back. This would be in front, so this would be kind of the belly and the chest. That's the back, and this is essentially just a transection right through a tubular structure. If this were coming in and out of the plane of the screen, and this H-shaped region is what we call gray matter. It's where the nuclei of specifically the neurons exist within the spinal cord. The neurons are the controlling cells that go out to the nerve roots, that control your motor function, your sensory function, and everything that goes in and out of the spinal cord goes through one of these segments, and there's 31 segments from top to bottom, where there's what's called a dorsal nerve root and a ventral nerve root. Those aggregate into this gray matter where the cell bodies exist, and then there's a whole amalgamation of fibers that run up and down the spinal cord. That's what makes up all this other substance or white matter. So outside these nuclei, as these fibers come in and out, they travel to and from essentially the brain. So it's a common pathway and conduit for that. The central canal, and we're going to focus on the central canal and Syrinx, exists right in the center of this, and that's really a derivative of embryology, as the spinal cord actually starts as a flat plate, and over the first 5-6 weeks of gestation, it starts to infold on itself to the point where it's a cylinder, and over time, that cylinder then moves into this element, which is called the central canal, and that's full of CSF on a microscopic scale. You can pretty much, with MR today, because the resolution is so good, actually see this on MR if you look closely enough with the right sequences. So the central canal is a normal part of everyone's spinal cord. It's not pathologic, and that rests essentially right in the middle of that gray matter substance and all these crossing fibers. The terminology in this Netter diagram, so I remember early on when I was trained in neurosurgery, it was a bit confusing. Syringomyelia, hydromyelia, syringohydromyelia, myelomalacia, all these terms start to merge to some degree. And for most clinical purposes, most clinicians are approaching those entities referring to them collectively as a syrinx. Histologically is where that delineation comes from. And that has to do with the strict terminology of hydromyelia is just a dilatation or increase in size of the central canal. And the important feature there histologically is that the normal cellular substrate that surrounds the central canal it still has its integrity and it hasn't been disrupted. So those cells are stretched, but they still contain those normal lining of cells that go around the central canal. And that's the strict histologic terminology. And then if you were to go into the realm of pathology, syringomyelia depicted here, which are not necessarily accurate in every situation, because most of these do communicate with the central canal. And most of these that we're dealing with, especially in Chiari and tethered cord, are dilatations of the central canal that then break out of that ependymal lining and then go into the parenchyma of the spinal cord, usually a lot more central and not eccentric like this. But syrinx is reserved for those that are not lined entirely by that cell that surrounds the central canal, namely the ependymal cell. And we're going to go into the etiology in a moment. Syringobulbia, another term you might hear, and that's a syrinx cavity. These are all cross sections. This is a longitudinal picture of the spinal cord. Syrinx being somewhere in the thoracic or cervical cord, and we're going to show you some images of that. But syringobulbia is when that process goes up into what we call the brainstem. So brain connected to the brainstem connects to the spinal cord at the C1, first cervical level, and that stem between the brain and the spinal cord at the C1 level is referred to as the brainstem, which has different components. But when a syrinx cavity ascends and goes into the brainstem, that's what's referred to as syringobulbia. And there are very classic symptoms that go along with that, especially in the infant population in Chiari too, that are very, very important from the standpoint of diagnostic sensitivity. One thing I will say about syrinx, and again, I wouldn't say it's a junkyard term, but you have to be very, very careful about the interpretation of syrinx, like we are with Chiari from a radiographic perspective. So when the radiologist says that there's a syrinx, it means very, very little to me other than the fact that there's some cavitation within the spinal cord. It doesn't tell me anything about pathologic substrate, clinical symptomatology, why it's there. But one very important issue that one needs to differentiate, these are sagittal T2 MRI scans. If a patient was standing like so, facing that part of the auditorium, this is the back of the neck. These are two different images, two different individuals. The back of the neck here, the back of the head. This would be the front of the neck, the front of the neck. These are the vertebral bodies stacked up in the cervical spine. Brainstem, cerebellum. And then you can see here on the right that this expansion of the cord, this is normal dimension of the spinal cord. Then you see this in this particular sequence, a very large white thing in the middle of the spinal cord. That's what we call iso-intense to CSF, and that is essentially CSF inside the spinal cord, a syrinx cavity. But look what happens to the dimension of the spinal cord here. It looks like it's about to burst. It's very, very distended. This is what I refer to as cord expansion. When I'm curious about symptomatic threshold, I'm usually thinking of, is the cord expanded beyond the norm? So you could look at this dimension down here. Is it bigger or smaller? And that's in contradistinction to this spinal cord here, which again would be labeled as a syrinx. But what's different about this area of a syrinx versus this area of a syrinx? Anybody? I'm trying to keep everybody awake, except for the two youngsters. Yes, sir. Go ahead.
What was the question again?
I asked the question, what's the difference between this part of the spinal cord and this part of the spinal cord? Which one looks bigger?
The one to the right.
Yeah, good. Okay, fantastic. Give them an MD diploma. There you go. So this spinal cord is smaller in dimension. That cavity is not because of a pathologic circulation of CSF in the spinal cord. It's because of loss of structure. It's what's referred to as myelomalacia, or loss of tissue. So this is a phenomena that's very common in the central or peripheral nervous system, that when you lose substance, it gets smaller, but it's filled in with usually CSF or fluid. So these are very, very disparate in my mind as far as my antennae going up and whether or not someone's got symptoms from one versus the next. They can still be symptomatic, but this we can do something about. This we can rarely do anything about. So it's loss of substance. Think of it as a stroke. That's one way of thinking of it, or an injury where you've lost substance, versus something that is distended and distorted because of accumulation of CSF. Very important distinction in Syrinx terminology. Okay. I wasn't keeping track. How many people of the 11 respondents said they had a Syrinx? Anybody remember? Let's find out. One. So what was your presenting symptom? So these are very common symptoms that one would have with a syrinx cavity. Pain, spine deformity, sensory dysfunction, motor dysfunction, and then other. And I'm going to go back to these individually. So of 6 individuals, pain and sensory dysfunction, or others, 2/3. Are those individuals in the room? What were the others? Was anybody vote?
It's nerve pain, loss of usage of my hands.
Okay, so because of sensory or motor dysfunction, could you discriminate? Numbness or weakness?
Numbness. I had no feeling in my hands.
Yeah. Okay. Same thing. Yeah. So the overwhelming majority of patients will complain of sensory disturbance, usually, not always, upper extremity, what we call paresthesias or hyposthesias. The fingers feel as if they're numb. A lot of individuals will describe it as carpal tunnel-like syndromes, and they have to flick their hands to make them feel better and try and get blood circulating through their hands. Depends on the age of the population one's talking about, but the other big, probably second to that, would be spine deformity, especially in the pediatric population. And usually they're sent by the orthopedic surgeon who's done a screening imaging study because someone's presented with we can get into it if everyone's interested, but atypical form of scoliosis or non-idiopathic scoliosis, which is the largest category of spine deformity that we see in adolescents. Motor disturbance is exceedingly rare. That's why I was asking the question, Brenda, is because of weakness or sensation. You'll see motor disturbance rarely, and we've actually reported on masquerading things such as disc disease with a foot drop, from an overt syrinx. So, one needs to be open-minded. One needs to be aware of the fact that this is going to be highly variable. But the overwhelming majority, upper extremity, paresthesia, sensory disturbance, numbness. Second to that is spine deformity in the pediatric population. Pain, yes, but it's usually in the way of not back pain, but extremity pain. What we refer to as allodynia, or referred neurogenic pain, can occur not infrequently. And I think in our PowerPoint, we're going to go to question number 6, if I'm not mistaken. If you do have a diagnosis of syrinx, do you know the cause? So, obviously with the content of what we're talking about today, most of this is emphasizing Chiari, primarily because Chiari is the leading etiologic factor or cause of syrinx that we see, but by far it's not the most common. So let's look at results here. So interesting, so not everybody here is afflicted with Chiari who's voted. So of the others, can I just hear anybody's comment as far as the cause or etiology of their syrinx? Who voted for non-Chiari? Anybody want to volunteer?
My syrinx actually got, it shrunk with my decompression, but it shrunk and almost completely deflated and has never come back since my fusion.
Right, okay.
So.
Okay. So is it the Chiari or is it due to something else that we can go into? So just to comment on that, so the fusion was or was not done in conjunction with another decompression, ventral or dorsal decompression,
No,
repeat decompression?
No, the decompression was separate, and the fusion was done before to 07, 3 years later.
Okay. All right. Yes, ma'am.
I just have a question regarding syrinx. So if you're diagnosed with a Chiari malformation, and at that point in time your MRI doesn't show that you have a syrinx, can you develop a syrinx later on in life?
I'm not going to answer your question now because I'm going to address that. Yeah,
Okay.
It's a great question, and it's a very germane question because of the overwhelming majority of the individuals that end up in my office don't have symptoms from their radiographic diagnosis of Chiari.
So I answer unknown because I have no idea.
You what?
I answered unknown as in
Okay, all right, that's
it applied to
fair.
me, I guess.
Anyone else with a different etiology cause?
Idiopathic.
Idiopathic, great. Great topic for discussion that we're going to get into, which I love that topic because it's it demands more work, and that's why I'm fascinated by it. So thank you. So let's move forward, I believe. That was 5 and 6, I believe. So let's talk a little bit more about etiology. This is not exhaustive, but it's just kind of a sampling of what we need to think about in the clinic when we see somebody that has an MRI scan that shows Syrinx. So you start the gears rolling. As you structure office hours, the one diagnosis that I always tell my office to save more time for is the patient with Chiari or Syrinx. It's a very complex set of issues, and it's not complex in the way of mystique, but it's complex if one wants to be comprehensive and address the individual in a way that they should be addressed. And the problem here, and I'm sure that Dorothy advocates this all the time, lumping everybody into the same diagnosis, same treatment algorithm is so wrong and not going to benefit the patient in any way. So this is kind of a sampling of what one needs to think about. So in the cranial compartment, and again, I can throw anecdote after anecdote where I remember being referred a child many years ago with a Syrinx and a Chiari. Imaging studies of the cervical cord showed half of the Syrinx. Tonsils looked questionable. We finished the imaging sequence, and lo and behold, there was a tumor at the bottom of the Syrinx, contrast-enhancing mass. And I can go on and on with the anecdotes about the thoroughness of which you need to address this from the standpoint of looking for etiology. And the reason we exhaust this is, if we're going to come full circle, because the way we treat Syrinx is by going after the underlying pathology. Idiopathic is the one that escapes us that we're going to spend some time on. So if someone has hydrocephalus, certainly treated or untreated, it can still be the etiology. In the Chiari 2 population, the myelodysplastic, the number one cause for Syrinx progression is for shunt malfunction, so one needs to investigate that. And if someone's been treated, and I've probably in my career, just shy of 24 individuals I've treated for Chiari 1 by way of what's called an endoscopic third ventriculostomy, our first order of business is to make sure that their CSF fluid circulation or our treatment that we've instituted is still durable. Because if it's not, then we go back to treating that. Again, in the pediatric sector, we see a fair number of kids with cranial dysmorphology, craniosynostosis, skeletal dysplasias. These are extremely common in the cause of foramen magnum compression, not necessarily Chiari, but resulting in Syrinx that we always have to pay attention to. I won't go through all these in such detail, but you can get a sampling by looking at this. And certain of these, I will be honest, escape even the radar of a lot of clinicians who don't spend a lot of time in dealing with Chiari and Syringomyelia. Intracranial hypotension is kind of the last thing anybody would even think of. But you see more and more patients, you dig a little deeper, do the appropriate imaging studies, and that patient's going to be exceedingly grateful if you're identifying etiology that you can fix. And it's easy to go down this path of saying that, well, we did a decompression for intracranial hypotension, someone didn't get better. Of course they didn't. And so from the standpoint of what we want, from the standpoint of success of any procedure we throw at them is governed by this. Junction abnormalities at what's called the CV, or craniovertebral junction. We're talking about instability. We always should be doing dynamic imaging studies if this looks somewhat atypical, if it's not a typical Chiari 1 to Syrinx. And I'm going to talk about the diagnostic wherewithal in a moment. You see these other aspects that have to do with segmental issues of skeletal dysplasia or congenital aspects of the spinal cord. And then those basically within the spinal compartment, we talked about tumor, tethered cord. Again, if someone comes in with what looks like a Syrinx, no Chiari, no hydrocephalus, no intracranial pathology, you better bet that we're going to march down and look at the lower part of that spine to exclude tethered cord. Some would even do this up front for all Chiaris. That's a debatable issue. But again, looking for the etiology of Syrinx, it's a mandate. Trauma, trauma moves more into that image I showed on the left when this young gentleman said that spinal cord looks small, usually secondary to insult, and you get loss of tissue. And then others that are less well defined on imaging, but on history. Someone had a form of neonatal meningitis, or they had a fungal infection that spread to the spinal compartment. And then a couple of other rare forms down here, and I kind of already talked about hypotension and intracranial, or a CSF fistula. So one can talk about the pathogenesis and why fluid gets in the spinal cord. I'm not going to spend much time on this. I remember as a resident and a junior faculty, this always used to be kind of the pimp questions. Was it this person's hypothesis? I don't really care necessarily who proposed the hypothesis as much as can we reverse the pathologic substrate. So yes, understanding it is important. So if it, and I remember again as a resident, we used to quote unquote plug the obex, try and make a path of resistance between the intracranial compartment and the central canal of the spinal cord by putting a piece of muscle in there. And that's important to understand these from that standpoint, what therapy is going to be best. But I won't go into much detail about that. So we talked about sensory disturbance, and I'm going to just focus on two very basic elements of presentation and symptoms. And one is the sensory disturbance that we talked about, and I'll show you the anatomical reason now that you're all expert anatomists with regard to the spinal cord, so I can quiz you now. But and then the other is spine deformity. But the central canal that I depict here in blue, kind of enlarging and regressing, I just want to show you that the cause and the reason that is that individuals become symptomatic. We talked about these ascending and descending fibers of the spinal cord. That's kind of going into the screen, and then the dorsal nerve root and the ventral nerve root. Several modalities of sensation. When you touch something, you have pressure sensation, you have pain, you have temperature. We call it two-point discrimination. All these are different sensory nerve ends on these nerve tissues that allow you to discriminate between those different modalities. Is something rough, smooth, soft, painful, hot, cold. And some of those modalities right here, which is called the spinothalamic tract, come in the sensory nerve root, the back of the nerve root. It affects motor. And these cross right across the midline to go to the other side to go up to the brain. So all of these fibers for pain and temperature, those are the two modalities that have this crossing architecture, go right across the midline. So when this syrinx dilates, those are the first fibers that it seems to affect first. So in a real case scenario, in the examining room, when someone has a bad syrinx, you can actually see this based on what's called a dissociated sensory loss, that someone has great ability to feel pressure, but when they step in the shower, they can't discriminate between cold and hot. Someone will touch something sharp and it's not painful to them versus someone squeezing their finger where they feel a deep sensation of pain. And those can be separated based on a good clinical examination. And those are the most common sensory disturbances that we can see as we look for it in the office on an exam. So that idea of dissociated sensory loss is real and has a real good pathologic correlate or anatomical correlate. And then spine deformity is the other one. I'm going to show you this anecdotal case here because this is fairly classic in what we will see. Again, here's kind of the big picture, and this is where kind of national or international attempts to kind of converge and coalesce thought processes behind Chiari. So in those that screen for spinal deformity, which is a very common disorder in children, it's usually the orthopedic surgeon or the orthopedist, school nurse. It becomes very, very important for them to understand when should we pull the trigger and look for some pathologic substrate in the spinal cord. It's the minority, and some would say somewhere around 10% if you did imaging on most non-idiopathic scoliosis, that you're going to find some pathologic substrate. And it depends on a lot of features that I don't want to spend a lot of time on, but pain, is it a complex curve, is it rapid in onset, what is the age, et cetera, et cetera. But one needs to be well versed in when to look. Because again, you don't want to miss an opportunity to basically either reverse or treat something when in fact somebody might just put that individual in a brace or God forbid move forward with a stabilization, not stabilization, but corrective procedure when there's an organic basis for it. And spine deformity is a big one. And this particular child, not just the deformity, this is a youngster, 6 years of age, the Syrinx, and we can go into the etiology if you're interested in how a Syrinx causes a Chiari, and I'll spend a couple of seconds talking about it in a moment. But the other symptoms, when we see a child like this, they've got deformity, say it's 15%, they're fully functional, but you need to dig and dig deep, especially for a 6-year-old or a 4-year-old. Are they integrated into school the way they should be? Have they acquired their speech and vocal skills the way they should have? Do they have sleep apnea? Are they waking up in the middle of the night 4 times? Are they getting that type of effect from the Chiari itself? And if you look at a parasagittal cut, focusing more on the brainstem, here you see the signal change right at the brainstem. And this is a very typical thing where if you don't look for it, you might not find it. There's dysphagia. They pool food in the back of their mouth. And then I think there's a whole expertise built around diagnosing symptomatic Chiari in the young child. And I spend a lot of time on that because they're not going to come to you and complain about the same types of things that one of us might at our age. But one thing I want to say about deformity, this makes perfect sense. So if you get a dilatation of the spinal cord, I talked about those crossing fibers. So those motor fibers also that go up and down the spinal cord, they don't just go to the arms and legs, but they go to the truncal muscles, the things that help you stand erect and straight. And if there's asymmetry in the way those are innervated, the nerves that come out of the spinal cord to strengthen those muscles, if there's an imbalance of those muscles, that's thought to be the etiology of why you start to get curvature of the spine, because you get asymmetric tension on the spinal axis. In the absence of Syrinx, and I'd say that we still see at a fairly good clip because of our association with a very busy center like Hospital for Special Surgery, those that come over, got imaged, have no Syrinx, they have a scoliosis, and they have Chiari. So what about those innervation things that we spoke about? There are some theories behind it, and I think this makes great sense, that in a lot of Chiaris, there's asymmetric tonsillar herniation. The cerebellum is not equivalent on both sides. There's more compression on one side versus the other. And those fibers go all the way up through the brainstem as well. So you probably have the same effect even without Syringomyelia. What's not clear, there's less of enthusiasm for offering those patients decompression versus those with the Syrinx. I spent some time already talking about the kind of the dizzying, diagnostic endeavor here. 85% of the time, maybe even greater, it's straightforward. You get the MR, you get the MR of the spine, bingo, you've got your answer. But you go to someone like yourself with an idiopathic Syrinx, and guess what? She's gonna, I hope, she has undergone almost all of these studies at least once. And the reason there's so much emphasis on it is because if we can identify etiology, then we can potentially reverse the process, right? But then you also have to think about, is it symptomatic or not? So there's two other things at play there. But these are the types of things we have in our arsenal or toolbox. And this is not entirely complete. CTLS just means don't focus just on the cervical spine. Thoracic, lumbar, and sacral elements have to be looked at with contrast. So I got a Chiari, why do I need contrast? You want to eliminate, or I got a Syrinx, I want to eliminate the possibility of tumor. And I talked to you about that one anecdotal case. With MR, we have the ability to do essentially equivalents of myelography, where you're actually looking at the spinal fluid very well. But we still reserve CT myelogram in some situations where MR is escaping us. And it still has a role, and I wouldn't throw it out yet. Dynamic imaging, going back to the question about stability and Syrinx. So again, depends on the clinical scenario. I've been doing this for a long time, and if you read Jerry Oak's paper on 500 Chiari decompressions, and an amazing treatise on the right approach toward treating Chiari 1, he mentions in that commentary about giving up on the idea of doing dynamic imaging on all patients. I probably did it for the first 10 years of my career, and I kind of backed off just because I've never acted on it. But in the problematic patient that hasn't received the right type of response, or has a Syrinx and there's not the classic Chiari, or has some what we call osseous abnormalities of the craniovertebral junction, by all means. And you'll see this on sensitive MR imaging. But dynamic imaging just means we're going to put them in an MR or a CT or plain X-ray and ask them to go through flexion extension excursions, and those are important in some situations. MRV, again, we reserve it in some situations that we can spend more time later on. Some of these sequences are very brilliant. A lot has been made, and I don't know how I'm going to necessarily communicate this to you, because I'm sure everybody in here has probably had a phase contrast study. But a lot has been made about the utility of this sequence. And it doesn't seem as if it wants to play, but it's really an amazing resource, because if you take yourself out of the mindset of anatomical imaging, and now we're looking at flow dynamics. And flow dynamics is synonymous with talking about the pathogenesis of Chiari. Got a cranial compartment, got a spinal compartment, and if those don't talk, and it can happen anywhere, the craniovertebral junction, cervical level, farther down in the spine, if there is some aberration of pulsatility of fluid anywhere along there, you can get a syrinx. We see it from disc disease, we see it from spinal cord trauma, we see it from normal degenerative spine disease, that the spinal cord starts to expand, and it has to do with that normal channel of subarachnoid fluid running up and down the spinal axis. So now we've got an imaging modality that can look at that. And all that is essentially a grayscale image where black is in one direction, white is in the other, and it's 180 degrees out of phase. So fluid in one direction is going to be black, fluid in the other direction is going to be white. You can actually measure velocity, and very, very exquisite ways of doing this. So these look fuzzy and difficult to interpret, but I'll also say in the same breath, I almost never use this for diagnostic purposes with a Chiari one. I've been fooled more times than not. Flow sensitive sequence comes back and says, it's abnormal. So someone doesn't have any tonsil herniation. And the reciprocal is more common, where we see overt Chiari symptomatology, Syrinx. Somebody's done a Cine sequence, and it'll be read as essentially looking normal. So one has to be a little bit careful about the interpretation and understand what they're looking for. And it does serve a purpose, but it's very, very exquisite as far as what we can actually look at with regard to flow dynamics. So Syringomyelia and Chiari Malformation, I talked about the incidence in surgical series, and surprisingly, more times than not, you see, well, if the problem's up here, why doesn't it involve that? Because you got compression there is the real reason, because the cord can expand where it's maximally compressed. And we talked about really some of the reasons why, and it commonly has this view like, it looks like, Haustra is the wrong word for this group, but these different balloons or compartments associated with the syrinx. They're all in communication, so patients will sometimes ask, do you need to treat each one of these syrinx cavities? And I think I showed you some other elements where it looks like there's some skip lesions, like, where was it, here? No is the short answer. These all communicate through the central canal or through the syrinx cavity. Other than infectious processes or trauma, assume that these all are in communication at one point or another along that axis. So it showed you some images, T1, T2 sequence, dilated cord, tonsillar herniation. We talked about syringobulbia, so you've got a syrinx down here, overt Chiari, and you see this signal change, this white spot in the brainstem. These are the types of patients that are going to present with things like dysphagia and central sleep apnea. And these are very, very sensitive tools that we use when we're equivocating about the right form of treatment or even treatment at all. An example here, in a recent case that I had seen. So we talked about sensory disturbance. So it'd be unusual to have facial numbness, arm numbness, as I mentioned, hand numbness. But as you start to go up in the cord, it makes perfect sense. And actually the sensory innervation of the face goes down to the C2 segmental level, so right about here. So if you've got a syrinx that's going up as the most top part of the cervical spine, it's perfectly acceptable and expected you're going to have some numbness of the face. You might have heard about something called a pre-syrinx state, and this is kind of a harbinger of something, we were talking about evolution, I think, of syrinx. So even though there's not an overt syrinx, some of the imaging sequences we use that are high-res T2, you'll see what's called signal change, but not an overt syrinx. There's no cord expansion. But there's clearly some signal change within the cord that most would say is kind of the predecessor of an overt syrinx. And this is just fluid getting imbibed in the spinal cord itself. And most of these go away when you give appropriate treatment, like a syrinx. That makes sense. Diagnosis, I show this because we were talking, I think Caitlin and I before, the patients that come to see you with the diagnosis of Chiari. So here's my MR report, and this happens so frequently. Here's my MR report. I was asked to see you for a decompression. They've got online, they've done their homework. But one needs to be so careful about the interpretation of just a strict MR report. And this is not really criticizing our radiologists and our colleagues in any way, but they do not have the clinical acumen is the wrong word, but the insight, because the patient's not in front of them. And so this is very common. So 2-month history of headache, non-exertional, so atypical Chiari headache, but the MR, and this is just someone we saw within the past couple of days, shows a small syrinx. So they come to see me thinking they need a decompression, there's a syrinx, and this is what the MR looks like. There's some motion artifact here, but there's some signal change within it. If you look at the axial section, there's some signal change, this white stuff within the central part of the canal. this is not a Syrinx, by any stretch of the imagination. So goes the case with this one. Very similar story. So a 30-month-old male. We certainly don't want to do surgery on somebody this age for all the reasons you'd expect. Worked up for constipation, had a diagnosis of anal atresia. There's a great cause for constipation with anal atresia. But this 30-month-old kid got imaged as a Syrinx. Syrinx causes constipation. That's the thought process. And here's his MR that shows this signal change within the cord. Here's the axial, so the transaxial slice, this little wisp of fluid. Now, if you were listening, the first slide, I think it was second slide, what is this?
Normal central.
Normal central canal or dilated central canal. So that's, thank you. You catch on quick, I love it. So that's what you're dealing with. So this is not a Syrinx. This is not, and it shouldn't be interpreted as something that should instill anxiety and concern and start leading someone towards signing a surgical consent. And this happens frequently. So be careful about the interpretation of the imaging studies. So if we see an individual, not we as in myself, but collectively, neurosurgeons who treat Chiari, and this is a paper that's cited quite commonly, survey sent internationally looking at neurosurgeons who treat Chiari, how does Syrinx play into your decision making? And I hate to say that one should be blinded, but I think I'm a little bit of outside the realm of norm here, and that so when Syrinx is seen in the presence of a Chiari radiographically, you see that if you get an asymptomatic patient, incidental finding, overt Chiari 1, without a Syrinx, less than 10% of individuals would offer, at least in that survey, treatment or surgical decompression. What about the asymptomatic patient with a Syrinx? Depends on the size of the Syrinx. It's kind of the impression you get here. But if you get up to that 5, 6, 8 millimeter mark, the overwhelming majority of individuals are going to operate, even in the asymptomatic patient. My fellow's here, and he's going to know that I wouldn't, but even if it's up to a centimeter. And I'll show you why in a moment. But Syrinx plays an important part in the interpretation by the practitioner as to the severity of a Chiari 1. I'm going to show you some evidence to suggest otherwise, and I don't necessarily believe it should. And obviously, if you throw in there the idea that there's spine deformity, almost all, and I think that's appropriate. And then Syrinx, without Syrinx and scoliosis drops to about 2/3. So in distinction to that is a recent publication looking at this Chiari Severity Index, where the authors, a very good group in St. Louis, have attempted to basically look at trying to consolidate in a way that takes the practitioner's subjectivity out of this. So what are the symptoms? What is the headache like? What are the radiographic findings like? So going back to these common data elements, trying to make an attempt to do this. And can we put that in a score that at least prognosticates to the practitioner and the patient what the expectation is that they'd see improvement? And it's a little bit complex. I don't want to go into the full imaging scheme here, but really on the imaging side, they only looked at one element, and that is, so they looked at a lot of elements that had to do with PBC2 line, the amount of descent of the cerebellar tonsils, degrees or angulation of the basiopistheon, et cetera, but the only one that really held any statistical significance was a Syrinx above or below, I think it was 6 millimeters in this particular series. And then they incorporate that into a clinical score, spit this out in severity scale of 1, 2, and 3. And what they found between the difference in Syrinx is that a larger Syrinx was a negative predictor with regard to outcome for the patient, so improvement or complete resolution of symptoms, which I think is a little bit of a paradoxical expectation for most of us. Then we see a big Syrinx, clearly they're symptomatic, we're going to operate and expect that they're going to get better. They commented on the discussion in that bigger Syrinx, chronic symptoms may be in complete resolution because of the chronicity, and I think there's some potential value there. This requires some validation, but nevertheless, I wanted to give you a kind of a snapshot of how Syrinx is influencing clinical decisions, even in the absence of symptoms. So how do we treat? Depends. Like any good politician. There must be a presidential debate since we've only got 15 people in the room. But how do we treat? It really depends on the underlying condition. Go after the underlying cause, your success rate will go up. And obviously the reciprocal holds true. So the take home here is define why this Syrinx is there and then go after that. I don't have to go into each one of these differently, but you can see how if you fall into one of these categories, you certainly don't want the wrong operation. Posterior faucet, so think about the implications of these from the patient's perspective. Posterior faucet decompression, tumor removal, shunt, venous stenting, repair of CSF fistula, Syrinx shunt. All these are representative and legitimate forms of treatment if it's directed toward the right person. So it's all over the place. But that's why the diagnostic endeavor is as it is. In the great majority of cases, we're doing a classic decompression. Tonsil herniation, C1 lamina and cross-section. And again, there's a lot of debate and there's a lot of effort to try and define, should the dura be open, shouldn't the dura be open? Probably a topic of another discussion, which I love jumping into. But, as every surgeon does, because what I do is right. But nevertheless, with or without duroplasty, adequate decompression to restore pulsations between the subarachnoid space of the cranial compartment and the subarachnoid space of the spinal compartment will be equilibrated with success. You know, it's not always an easy endeavor, but that's the goal of the operation, regardless of what you want to do. At the time of surgery, this is what you're attempting to see. These are the cut leaflets of the dura, and this is the cerebellar tongue. The patient's on their belly, looking straight down. We're looking at the back of the head. I won't go through the gory details of bone removal and dural opening, but this is what the cerebellar tonsil on the left looks like. On the right, here's the spinal subarachnoid space. And this kind of milky white stuff you see is what's called the arachnoid. And dynamically, as you watch this intraoperatively, it fills and empties with CSF. And that is, I always say, the movement at the time of the operation. You know, the patient will get better. And before that, this is plastered and smashed down to the cerebellum, and you're never going to get that pulsatility of CSF across there. So, if you've had surgery for syringomyelia, please indicate the form or type of procedure. Let's see what we got here. See if anybody's been treated. Look, Roseanne, I'm getting the hang of it. Not bad. So, Chiari decompression, Syrinx shunt, drainage, namely just an aspiration, tethered cord release, no surgical treatment. Of course, there'd be, as I just showed you, others. So no surgical treatment at all. I want to dive into that a little bit more, but there may be two patients, no, probably one. Wait, I have 7 votes. Someone do the math here. Decompression for Syrinx, tethered cord release, those are probably 1 apiece, and no surgical treatment. Can I just ask anybody to elaborate on?
You didn't have the option to put multiple choices.
Is that what this fulfills? Most of this is multiple procedures? No. No. Any shunts? Good. Yeah.
Well, my son had 2.
Yeah. So we're going to talk about that as far as a form, but it goes back to your question about idiopathic syrinxes as well, or thal decompressions is the big place where that's done. And I don't think we're going to go to our next question yet, but I remember one of the first papers I ever published on Chiari, I made the comment about syringo subarachnoid shunt, and the reviewers wouldn't forgive me for it. You know, it's an amazing effective forms of decompressing the Syrinx. The problem there is the durability. You know, how do you maintain it? So this is what we always want. This is without Syrinx. You know, overt Chiari malformation. Some would label this as a 1-5 tonsil hernia. And see how there's none of this white across this transverse section right here. So none of that CSF's getting across there. Post decompression, radiographically, we know with great confidence that that's equivalent with a successful decompression. So if symptoms don't resolve with that, then you pretty much have either the wrong etiology of the syndrome or the pain or whatever it is that got the patient in the office. But that's essentially what you want. We talked about the cine imaging. In failed Chiaris, I think it plays a role, but it takes a very, very careful interpretation, and I will stress, do not rely on the neuroradiologist's interpretation of it. So if you're going to use this type of imaging sequence, you better be using it routinely and know what the kind of the fail-safes are here and when it's going to lead you down the right or wrong path, because it can be quite problematic. That black to white, as I talked about before, and that's what you want to see. That shows you that demonstrations that of CSF pulsating in either direction. With a Syrinx, so dial back the clock for me 25 plus years ago as a resident, and it's not, I love NYU, and that's where I trained, and it gave me a great education. But I want to give you a chronological picture of the way we've evolved in our thought process here. This patient in my training, we would have done a posterior fossa decompression, dural opening, take a portion of the muscle, what we call plug the obex, put it in that canal between the fourth ventricle and the central canal. Then we'd go down to the thoracic cord, do a laminectomy, and put a syringo-subarachnoid shunt in there. And it worked, but you know what? This patient had a decompression with or without a duroplasty, and here you are essentially 3 months later. Ascension of the tonsils, complete collapse of that spinal cord, dilatation, and that's become the norm. So going from this more invasive, very, very kind of poorly defined rationale as to why we're treating certain elements of it, central canal, Syrinx shunt, etc. In the right circumstances, this works and works the majority of the time, and that's what we're going after. Another example of it here, with just 4 months later, look what happens to that cord just with decompression. So this part of the bone has been removed, Syrinx collapses, and again, we can go with all the nuances as far as surgery, how big the craniotomy should be, what dural substitute, you do intraarachnoidal dissections, those are all for a different discussion period. But I want to throw something else into the mix from the person who's making the decision with the patient. So as I talked about before, I cited that paper about the international survey about if a surgeon sees that there's a Syrinx above, what was the number I threw out, I forget now, 5 or 6 millimeters, that they're going to recommend surgery. I'm not of that school of thought. If I see somebody truly with an asymptomatic Chiari and Syrinx, even if it is above that 4 to 6 millimeter threshold, I tend to avoid surgery. I watch them very closely. I remember a couple years ago at one of the, I think it was the ASPN, American Society of Pediatric Neurosurgeons, we were talking about this, and Mike Scott, somebody I revere and value his opinion immensely in neurosurgery, stood up and said that absolutely not, because of the possibility of acute deterioration. And every neurosurgeon doesn't have to rewrite the textbook, but I have not witnessed that yet in my career when we sit tight on a patient with a Syrinx. So I show this because we were talking about the natural evolution of Chiari. So when I see a patient with an asymptomatic Chiari, with or without a Syrinx, I have a very frank discussion about the natural evolution as best we can. There have been some very good papers, University of Michigan, this one, University of Miami, Miami Children's Hospital, looking at the evolution of this. And it's hard because everybody's diagnostic criteria are different. So again, congratulations when you have a unified approach toward defining what is the entry here. But assume that these are, and they are, representative individuals who know what they're doing. What is the natural history in that situation? And I show this with a focus on the Syrinx alone. And what was interesting in this 140 plus patients, so of those, 8 of those demonstrated some progression of the Syrinx over that interval of follow-up. And it was somewhere, I think, radiographic follow-up of about 3.5 years, and clinical about 5 years, so relatively short, caution to be said there. But 8 demonstrating progression, so somewhere about maybe 6%. And that's usually the number that I cite to a patient when I'm sitting with their family. But look at this. So half of those, or a third, 3 of those of that same number showed spontaneous decrement or spontaneous resolution in the size of their Syrinx. So for no other reason, no treatment, all of a sudden their Syrinx is getting smaller. So again, some of the mystique that's thrown into this. And although I've cited that many times, it wasn't until the past 3 or so years that I've seen this, and I'm going to show you one example. This gentleman that I saw back in 2013, so he was imaged because of low growth hormone, stature which was low, growth hormone secretion that was thought to be aberrant. Got this imaging study, showed a Chiari, then we did the completion, and he's got this, so this isn't a Chiari malformation, this is actually a pulsatile turbulent flow pattern, which looks like a V. On a T2 image like this, the white turns black when there's fluid that's moving. Misinterpretation here is very easy. They diagnosed a Chiari malformation with a Syrinx. And he was entirely asymptomatic with regard to any type of symptoms. And at 10 years of age, most kids will be very forthright about things like paresthesias. So of course we did our due diligence, go down the lower spine, no tethered cord. no dysraphism, contrast, no tumor. So he was in that realm of, Chiari with an asymptomatic Syrinx. And what I usually do with those individuals, because of that small but real potential for progression, bring them back annually for an MRI scan of their spine. Usually I do a full spine imaging study at diagnosis, then just limit the annual scans to the cervical spine, because that's where the majority will be. If somebody's been never diagnosed and you want to if you want to really do your due diligence, you look at the entire spine. But for follow-up, I limit it to the cervical spine. That's my preference. And here he is 1 year after that initial assessment. You can clearly see that this whole thing has kind of collapsed a little bit. This does not look like an overt Chiari. So we spared him an operation. But again, if you followed suit that Syrinx means surgery, we would have operated on this kid who remains asymptomatic and now about 3 years out with no progression. So if you had treatment for your Syringomyelia, here's the tough question. Here's where I'm going to leave the room. Have you enjoyed full resolution, partial resolution, or no resolution? And then question 9, are you currently on any medication for symptoms of Syringomyelia? So let's take a quick peek at those responses. Don't throw any of the food that was kindly supplied. So full resolution, partial or no resolution if you were treated. I'm afraid to look at this. So not very impressive. Huh? So one lucky person out of 4 individuals who voted, partial resolution, but half. And this is not uncommon, and that's not anything that anybody should be proud of from a clinical series. Because you expand this, most would say that the partial to no resolution of symptoms is going to hover somewhere around 20% of all comers with Chiari. And how do we hone in on optimizing that and maximizing that? You could withdraw a little bit and not offer surgery to those that maybe need it. You could provide the right operation, and the list goes on and on. So there's a lot of stuff mixed in here, but this is only a sampling of 4 individuals in this room, but a 50% response rate is pretty embarrassing. And then the next question was, are you on any medications, muscle relaxants, pain medication, other? So no medications, yay, like that. And then others. What you don't want to see is that evolved individual that didn't get resolution, they're going through a whole series, and many patients do, sometimes effectively, muscle relaxants dependent on anxiolytics, Valium, et cetera, et cetera. And it gets into this whole problem of not having a concentrated, multidisciplinary approach toward this, so having the right physiotherapists, the pain management individuals. I've seen individuals with Syrinxes with great response post-decompression with horrible pain syndromes based on the rapid decompression of those cysts. And we've even gone the route of looking at spinal cord stimulation in that subpopulation. So it's not anything that's necessarily straightforward, and I wouldn't expect full resolution in every patient. That's why you got to be careful about the direction you go with treatment. So I think in the next several minutes, we're going to finish up and talking about idiopathic Syringomyelia. As mentioned, it's kind of a passion of mine just because I'm so fascinated and it makes no sense to me. I don't like the word idiopathic in medicine. It just doesn't make any sense. And it just means that idiopathic, idiot, kind of from the same derivation. Well, we just haven't done the right diagnostic studies, or we haven't figured it out. But so here's an example: 4-year-old youngster with juvenile scoliosis, never been treated. You can see the rest there. Absolutely no symptoms referable to such. And Jordan, who has been extremely good at kind of creating our comprehensive intake questionnaire. How many pages is it? Oh, good for you. Great. But, we really dig deep to try and find out if some of the less obvious symptoms might be present. And I spoke about some of those with things like feeding patterns, snoring, dysphagia, etc. Exam doesn't show anything, as most Chiari patients and Syrinx patients will not show any symptoms. But a scoliosis with a curve to the left, no papilledema. So essentially an individual with a Syrinx and no imaging studies to support an etiology. So here's a craniocervical junction. You see this dark fluid here. Again, that's dropout of signal from pulsatility of fluid going through there. That looks great. Aqueduct is open, that dropout of signal there. Here's the cervical spine, expanded cord, Syrinx, not subtle. very, very good flow patterns at the cervicomedullary junction, no tethered cord, etc. So what do I do with that individual? I dig and I dig deep. And actually, I remember the reason I had these films is because I went into my little Chiari file up on my desktop a couple days ago and dug this up because I had actually put this together. And it used to have on here comments like, what would you do next? Would you do a myelogram? And I remember sending this to some of my trusted confidants in neurosurgery probably 6 or 7 years ago, people like Benny Iskender, Jerry Oakes, Michael Scott, asking them what they would do next. And so the reason I show this is because it introduces the concept of Chiari 0. So idiopathic scoliosis or Chiari 0 or the amalgamation of one term. And this is a tough thing to try and decipher. But Benny, who when he was down in Alabama, published this report first in 1988, talking about, I think it was maybe 5 patients, excuse me, who presented with bad Syringomyelia symptoms, no evidence of Chiari, no tethered cord. They eventually went the route of doing a decompression, and some fraction of those patients improved with regard to their Syrinx resolution. They followed it up several years later, same group, with of 405 patients, 15 that they defined as a Chiari 0. So you can see the very few numbers that we're talking about here. So, and it's a rare entity. But again, idiopathic scoliosis or Chiari 0. I think I go about it the same way. I look hard for an etiology, but look at their response rate with regard to decompression. So low incidence. So the great majority had either what they refer to as significant or complete resolution of symptoms, and almost all showed a reduction in Syrinx with a standard decompression, even though there was no quote-unquote tonsil herniation. Very meaningful kind of clinical observation, and they comment on what they found at the time of surgery. So if you add this together, 10, 11, so maybe in their idea that about 2/3 they could find a cause. So how does one approach this? How do I approach this? We go through very, very high resolution MR imaging of the craniocervical junction of the spine. These things called, and there are sequences, not that you have to remember those, but this is where the practitioner who's very, very well versed comes into play, looking at CISS images or Fiesta images, imaging from the head down to the toe, using contrast enhancement, and then following these individuals very closely. But this becomes very important, and whether one buys into this idea that that patient deserves a decompression with an exploration or not is up for debate. But again, this observation that they see such a great response in that population, at least from a very reputable group, kind of has won my approval and my mindset. So in closing, if I haven't gone too long in this, so the take-homes, Syrinx, no question, one should dig and dig hard and spend time looking for an etiology. And I can't stress that enough. And you want to come up with the correct etiology. And because Chiari and Syrinx go hand in hand, and 80% of the time, does not mean that every time someone's seen with the Syrinx, one should jump to do the Chiari decompression. So one needs to be very comprehensive. The best way of treating is if you've done your homework and looked for the appropriate etiology, then you go after that etiologic factor. And those are, I think, the 2 take-home messages that I want to stress to this group. And then we'll close by going back to some of the questions that you posed to us earlier. Why don't all Chiari malformations have a Syrinx? Anybody want to take it? Come on. What's your son's name? I'm sorry. No, I'm sorry.
Not all Chiari have Syringomyelia. That's a good answer.
That's a good answer. Neither do I. It's not known. So one might imply or kind of hypothesize that it's just a natural evolution if you leave it alone, that they all will, especially given that information I talked about with regard to a pre-Syrinx state. The problem with that is if you look chronologically along age groups, it doesn't follow suit at all. You'd think that the young adult versus the younger child would have a higher incidence of Syrinx, and it's probably just the reciprocal in my estimation. But truly it has to do with probably the degree of compression. That falls apart a little bit when you look at extent of tonsillar herniation relative to Syrinx. They kind of fall apart. They're somewhat discordant. So it's a little bit of an enigma as to why that's the case. Chiari malformation without surgery, what's the main concern? Two main concerns. One is the natural history and the evolution that I commented on from that paper by Jennifer Strahl from University of Michigan. I cite somewhere between 6 or 8% progression rate over about 5 years, and I follow them up with annual MRs of the cervical spine. The other concern that we didn't get into, which is a whole other topic, level of activity with the known Chiari. So that's the other logical one. What's interesting is that before someone's diagnosed, most of these individuals, and we were talking about with somebody in the office today about gymnastics. Before they got their diagnosis, they're a gymnast, blah, blah, blah. And this is very common. Someone's gone through most of their childhood with not having a problem. So when does the clinician or the practitioner lay down the law and say that you should or should not be doing this? And I can tell you there's absolutely no consensus. Next subject you got to tackle there, Dorothy. And then if a Syrinx goes untreated, what are the real long-term effects? I showed that paper about the severity index, but I think it's unusual. And again, I give patients or their families every ability to choose the therapy in conjunction, but I don't see that the chronicity of this has worked against the resolution of symptoms in my experience. And I don't care how overt the symptoms are at presentation, short of a post-traumatic episode. But I am very, very optimistic about resolution of symptoms with a Chiari that's there. So I don't feel any urgency to get into the treatment issue. How do you manage your pain and why the medications don't help the pain? Probably because a couple of things. You didn't address the right cause for the pain. So let's take decompression as an example. Was the decompression adequate? And it's striking to me, and I don't want to get into the whole debate about duroplasty or not, but recurrence rates or reoperation rates in that population, 15%-ish, in most series. If you don't do the right operation, you're not going to have resolution. But I showed you that MR and said, listen, you get a decompression that looks like that with great flow. If someone has persistent pain, guess what? We probably didn't diagnose the right etiology. Nothing's worse from the standpoint of the individual who is now going to try and take care of it without having the right etiology at hand. Is there a cure for Chiari? No, not at all. There's the treatment. There's a very effective treatment, but one needs to be very, very disciplined about patient selection. And then, does Chiari 0 cause Syringomyelia? By definition, Chiari 0 has Syringomyelia. So there's the answers to your questions. Hopefully they're sufficient. Thank you for your attention, and I'll take any questions if we have time. Appreciate it. Yes, ma'am.
So I just wanted to go back to the question that I asked about if you had Chiari Malformation 1, but not Syrinx at the time you were diagnosed. Mm-hmm. Eventually you said that you will get a Syrinx?
Nope, not at all. No, just the reciprocal. You're unlikely to ever develop a Syrinx. So I cited one paper, and there's a couple of really good papers out there that look at the natural evolution of asymptomatic Chiari malformations. So what they do is they look at progression of symptoms, and they look at worsening radiographic findings. In that paper from University of Michigan, of the 147 patients, 8 developed either a worsening of their Syrinx or a new Syrinx. So that's kind of the best estimate out there. So somewhere around 5 or 6%. If you don't have a Syrinx, that you're at risk over 5 years to develop a Syrinx. It's pretty low.
Yeah. Would you recommend like an annual MRI?
Definitely. Yep. And that's what I think I suggested, is a cervical spine MR on an annual basis, what I do. Yeah. Now it's easier in somebody your age, but you take a 4-year-old who's going to have to get sedated every time. So I tend to space it out if there's stability over 1 or 2 years. Yeah, and no symptoms.
And lastly, I'm sorry for all the questions. This is actually my son, he's 13, he's diagnosed in January. He had headaches, dizziness, and neck pain. He doesn't have a Syrinx. I actually saw Dr. Greenfield. I guess the symptoms kind of went away with physical therapy and nortriptyline daily, but they kind of came back afterwards. Is that normal? Like from one day to another, can he develop a new symptom, or does it happen gradually?
Paroxysmal symptomatology is very, very common in Chiari as an etiology for these pain syndromes. So it's some will say, I always feel this tightness, and I felt it for years, and but more typical are the very, very transient pain syndromes that come and go. And it depends on many factors, what they're doing, level of activity, exertional issues. All these play a role in the recrudescence of symptoms. And if you start throwing analgesics into the equation, of course it's going to masquerade some of these, there's no question. So I find that variation of symptomatology is quite common. So anybody who practices in this field, if there's ambivalence about the diagnosis and is it symptomatic or not, the atypical headache, which is very, very difficult to try and pinpoint, I'll send the patient out. Here's your journal. Record when they're having symptoms, what they're doing. And then the other logical one that I think is a real telltale from a parent standpoint is the youngster extracting themselves from out of normal play activities. So they love to play soccer. Are they still participating at the same level? I'm not complaining of headache, but they're not engaged anymore. As soon as I hear that there's some element of withdrawal from normal activities, what they were doing a couple years ago or last year, to me that's a real indicator that something real is going on there. So I probably didn't answer your question directly, but I don't think there are any rules in this, honestly, as far as what to expect, when the symptoms are there, do they come and go. But the one thing that always holds true in most patients, if they're not fully resolved after X number of weeks, then I get a lot more interested in whether or not there's an association between what's going on there and their symptoms. But again, the majority of reasons people are going to have headaches is because of something that doesn't have to do with the Chiari, regardless of what the MR shows. Right? But again, the classic tussive headache, occipital, there's no better prognostic indicator that there's going to be a response to treatment if those are part of the complaint. Any questions?
Have there been any papers written on like collagen with spinal cord and Syringomyelia?
You're going to demonstrate my ignorance here. I don't know is the short answer. So collagen vascular disorders, definitely.
I'm thinking about when we talked tonight, and I don't know if there's any literature on it.
Yeah, I honestly don't know. I'd have to plead ignorance there. What fascinates me is, and Jeff and I talk about this a lot, is the idea that there's a real hydrodynamic factor behind Chiari, that tonsil herniation is kind of an epiphenomena of it. And we say this just because of the sporadic times we'll see somebody with overt papilledema and raised intracranial pressure who are diagnosed with a Chiari malformation, but no ventriculomegaly. The times we see venous occlusion of the deep sinuses and manifestations with a Chiari. The spontaneous CSF fistula in the spine and tonsil herniation, Syringomyelia from intracranial hypotension. I mean, clearly the pressure dynamics are real, but can you unify it all and say that they're all being governed by one process? I don't think so. I mean, this is I think it's an epiphenomenon of a lot of different processes, like Syrinx. And I showed you kind of this
that's
list.
That's what I'm thinking of, like Syrinx. Why do some people understand Syrinx and not don't?
Yeah. Was that your question then?
No, I don't know.
What else you want to mention about the Syrinx? No. Yeah. But I don't know about the issue of those assays. You know, Raphael? Yeah. Anybody else?